Today we're going to be covering Chapter 6, the School Health Program, a component of community health. Here are the chapter objectives for Chapter 6. The school setting is a great equalizer. It provides all students and families, regardless of ethnicity, socioeconomic status, or level of education, with the same access to good nutrition and physical activity. Because children also teach their parents, important lessons learned at school can also help the entire family. The Whole School, Whole Community, Whole Child model, abbreviated WSCC model, is a model focused on addressing the educational and health needs of children within the context of the school setting. So this entire chapter is going to focus on how the school plays a large role in public health. So communities strengthen and can boost the role of the school in addressing child health and learning needs, but also can be a reflection of areas in need in the community. It provides a shared framework and approach for schools and the community to work together to provide a systematic, integrated, and collaborative approach to health and learning. Here is an image of the whole school, whole community, whole child model and the collaborative approach it takes to learning and health. For the WSCC efforts to be effective, a great deal of time and effort must be expended by individuals in schools with an investment in the health of students. When these individuals work together to plan and implement a school health program, they are referred to as the School Health Advisory Council. They're sometimes called the School Wellness Council. An ideal council would include representation from each of the model's components, and district administrators, parents, students, and community representatives involved in the health and well-being of students. For the successful implementation of the work of this group, a full-time or part-time school health coordinator is critical. The school health coordinator should have an educational background that includes training in school health, and they should be able to plan, implement, and evaluate the model's efforts. The school health coordinator helps maintain active school health advisory councils and facilitates health programming in the district. Most often, the school health coordinator is a health education specialist or a nurse. The school nurse can provide great leadership for the school health program. They typically have medical knowledge and formal training, and they have multiple responsibilities, including developing individual health care plans, providing infectious disease information, providing care for medically fragile students, conducting physical assessments, utilizing technology to support management of records and assessment intake, and they support efforts to decrease absenteeism. Many school districts do not have the resources to hire a full-time school nurse, or the caseload is such that additional duties are not feasible. Oftentimes, schools contract with an outside health agency, such as the local health department or hospital, for nursing services. When this scenario occurs, the contract. On the average day, teachers spend more waking hours with school-age children than do the parents of many children. A teacher may spend 6 to 8 hours a day with any given child. Teachers are also in a position to make observations on the abnormal and normal behaviors and conditions of children because they are able to compare the students in their classroom each day. Furthermore, many health teachers are receiving leadership training regarding WSCC in their undergraduate and postgraduate work. Thus, this makes them ideal individuals to lead the coordination. The primary role of schools is to educate. However, an unhealthy child has a difficult time learning. You know how difficult it is to study for a test, or even to read a textbook when you do not feel well, or are depressed or hungry. Schools cannot achieve their primary mission of education if students and staff are not healthy and fit physically, mentally, and socially. Educational progress will be profoundly limited if students are not motivated and able to learn. Health-related programs play a major role in limiting the motivation and ability to learn of youth. The true foundations of any school health program, are school administration that supports the effort, a well-organized school health advisory council, and written school health policies. Without leadership and support from the top school administrators, it will be an ongoing struggle to provide a quality program. Furthermore, every effort should be made to employ personnel who are appropriately trained to carry out their responsibilities as members of the School Health Advisory Council. School health policies include laws, mandates, regulations, standards, resolutions, and guidelines, which provide a foundation for school district practices and procedures. Well-written school health policies provide a sense of direction and a means of accountability and credibility, and strengthen the possibility that a school health program will become an institutionalized part of the school culture. They also serve as an important indicator of where school health is prioritized within the overall education agenda. The steps for creating local health-related policies include build a policy and development team, assess the environment, conduct a needs assessment, draft the policy, adopt the policy, implement the policy, measure and evaluate, and then communicate the results. The development of a written set of policies is not an easy task. This challenge is time-consuming and should be executed by the School Health Advisory Council because the council includes the most knowledgeable about the school health program in addition to representing many different constituencies in the school community. Once the policies have been written, it is important that they receive approval from key stakeholders. A stakeholder is anyone that has a lot of game in the issue. So although the school board is the final authority that adopts policies, approval from school administrators, school-based committees, parents, and other key stakeholders can aid in the implementation process. The approval process provides credibility to the policies as well as legal protection for those who must implement the policies. The policy should also cover all facets of the school health program. This may include access to prescription medications, bullying, use of physical activity as punishment, foods permitted at school parties, policies associated with curriculum, health services, or maintaining a safe learning environment. The development of these written policies is an important step in building a solid base for whole school, whole child, whole community efforts. However, if the policies are never implemented, the school district will be no better off than before their development. Implementation begins with the distribution of the policies to those who will be affected by them: faculty, staff, students, and parents. Some ideas for carrying out this process include distributing the policies with a memorandum of explanation, placing the policies in both faculty, staff, and student handbooks, presenting them at gatherings of different groups, holding a special meeting for the specific purpose of explaining the policies, and placing them in the school district newsletter. News releases might even be considered if the policies include major changes. Each school district must decide the best way to disseminate its school health policies. Because of the requirements of the Child Nutrition and WIC Reauthorization Act of 2004 to implement a school wellness policy by districts, many resources have become available to help schools develop policies. Action for Healthy Kids is one such organization that is advocating and providing support for helping schools become healthier places so that kids can live longer and healthier lives by fighting childhood obesity, undernourishment, and physical inactivity. The Division of Adolescent Health at the CDC has periodically conducted a national survey to assess school health policies and practices at the state, district, school, and classroom levels. The survey, which is titled the School Health Policies and Practices Study, or abbreviated SHPPS, is used to do the following. It describes the characteristics of each component of school health at the state, district, school, and classroom level. It describes the professional background of the personnel who deliver each component of the school health program. It describes the collaboration among staff from each school health component and with staff from outside agencies or organizations, and it describes how key policies and practices have changed over time. If implemented appropriately, a coordinated approach to child health and learning can have a significant positive impact on the overall health status of students, staff, and the community, which in turn can be linked to higher academic achievement for students. But in order to do so, the 10 WSCC components need to be provided in a coordinated fashion. The first step is the administration and organization. The model should be administered by a school health coordinator, and again, this should be a trained school nurse or a health education specialist. They should be trained professionally at the state, district, or school level, who is responsible for managing, coordinating, planning, and implementing and evaluating school health policies, programs, and resources. This position is often not required by states. School health services should also be implemented. These can include wellness promotion, preventative services, and education, access and/or referrals to the medical home or private health care provider, support connecting school staff, students, families, community, and healthcare providers to promote health of students and a healthy and safe school environment. Here is an image of the framework for 21st century school nurse practice. The next step is a healthy school environment. By law, school districts are required to provide a safe school environment. This can mean physically or emotionally. So the physical environment includes the school building and its contents, the land on which the school is located, and the areas surrounding it. And then also the psychosocial environment. So this includes the attitudes, values, feelings of students, staff, faculty. There must also be the development, delivery, and evaluation of a planned curriculum. The priority health content for health education should include alcohol and other drugs, healthy eating, mental and emotional health, personal health and wellness, physical activity, safety/unintentional injury prevention, sexual health, tobacco, and violence prevention. When developing sources of health education curricula, there are many sources from which people can pull from. So there are many available sources from national specialists, state departments, health agencies and associations, and there are also commercially produced curricula. Whatever source is chosen for the health education curriculum, national health education standards should be met. This may include some of these standards. For example, the first one says students will comprehend concepts related to health promotion and disease prevention to enhance health. Counseling, psychological, and social services are services provided to support students' mental, behavioral, and social emotional health. These services can include individual and group assessments, interventions, and referrals. Professionals such as certified school counselors, psychologists, and social workers provide these services. Fostering school employees' physical and mental health results in positive role models and employees who are more productive and less likely to be absent. Employee wellness programs and healthy work environments can improve a district's bottom line by decreasing employee health insurance premiums, reducing employee turnover, and cutting costs of the substitutes. Today, many of the leading school discipline problems are related to health, such as bullying and other forms of violence, drug use, and the consequences of low self-esteem. Another issue is a lack of support for the program. Although many Americans support the idea that everyone is entitled to good health, we have not supported through legislation the notion that everyone is entitled to the whole school, whole child, whole community effort in our schools. Obviously, getting legislation passed is a complicated process and is dependent on a number of different circumstances, including but not limited to economics, social action, and politics. Additionally, limited resources, lack of buy-in and investment, the inability of schools to demonstrate competence and effectiveness to stakeholders, lack of organizational capacity, leadership support, and continued emphasis on high-stakes testing have made it difficult for school districts to make this effort a priority. Controversy also continues to be a challenge for health education for a number of reasons. Part of it deals with the pressure that has been applied to schools by conservative groups. Lack of awareness, knowledge, and skills is not an excuse for undesirable health behavior. If students do not get information at school, where will they get it? Studies have shown that there is often improper implementation when health education is provided by individuals other than health education specialists. This includes institutions of church and family have taught little about the controversial topics included in standard health curricula. It's not that these people are incapable of teaching health, but they have not been educated to do so. Reliance on a textbook as the curriculum, lack of awareness or implementation of state or national standards, an emphasis on content rather than skills, and limited, if any, coverage on topics that cause discomfort are some of the outcomes of improperly prepared teachers in the health classroom. The long-term result is young people often do not learn the skills necessary to live a healthy lifestyle. And you can probably think of a time this occurs. It's often in sex education. We have a majority of states that don't teach comprehensive sex education, and some that are forced to only teach abstinence. And as we're probably aware, abstinence-only sex education is not effective. School-based health centers increase access to health care, eliminate barriers, and improve health outcomes for essentially every patient enrolled. It's provided in different ways, but most commonly it is located on school property. Early on, school-based health centers were frequent targets of intense criticism at local and national levels by political and religious groups. Much of the controversy surrounded school-based health centers centered around cultural wars and partisan politics. So providing comprehensive health education and providing health care on school campus was often politicized, right? Liberal versus conservative. We shouldn't be providing, an example would, we shouldn't be providing students with condoms because that's going to increase their desire to have sex, right? Which isn't accurate. That's not what we see in the data, but it invokes a lot of emotion in people and it becomes very political instead of focusing on students' health. There are often always funding challenges too. Over the years, schools have been viewed as a safe haven for teaching and learning, but in recent years there have been a number of high-profile incidents of violence in schools that have made the general public more aware of violence in schools. Any instance of crime or violence at school not only affects the individuals involved, but also may disrupt the educational process and affect bystanders, the school itself, and the surrounding community. For discussion, think about these questions. Why is a whole school, whole child, whole community model so challenging to implement in every school district? Also, how can schools have more effective health programs with limited funding?